Henry, could we have up, please, THOM 60...
Just 1 minute.
Sorry.
We're just a little early.
Sorry.
No, it's my fault for starting just a bit early. Don't worry. Right.
So THOM 601, please. So this is the oral history project again, Professor Lee. Could we go to page 27, please, Henry? And just look at the bottom 6 or 7 lines. You're talking here about hepatitis C testing, hepatitis C testing coming in. And you say, so in the context today, we have patients going around saying they never told us anything. They never told us, but they knew and we weren't told till 1991. And of course, it's very difficult for them to remember. We would have been talking about them having abnormal liver function tests, but we don't know what this means, and you're very well and all the rest. And it wasn't until 1991 that we actually told them, well, actually, you've been infected with hepatitis C. Now, were you saying there that the information given to patients, as far as you know, prior to the availability of the Hep C test, was about them having abnormal liver function tests rather than specifically being told that they had non-A, non-B hepatitis?
Yes.
If patients were told prior to 1991 at the Royal Free that they had non-A, non-B hepatitis, would you expect that to have been recorded in the notes of the relevant individual patient consultation?
Probably depends who saw them.
So
mostly I saw them, but not always. Some reviews were done by other doctors. I think I probably would have done. I don't know.
So, so that I understand this correctly, if you had been seeing a patient and telling them about non-A, non-B hepatitis, so this is before the HCV test, if you told them that they had, or you believed they had non-A, non-B hepatitis, you would have expected that you would have recorded that in the notes?
Probably, yes.
You can't necessarily speak for others?
No. And of course, the importance of the review and the importance for considering the abnormal liver function tests and the liver was because if we sensed there was any abnormality or things were not going well, and then of course when we move on and we've got treatment, we can actually refer them to the joint liver clinic, which I established when I became the director, where I think they roughly were about every month. It rather depended on when the consultants, hepatologists, could come down to the clinic, and I would sit alongside him in that clinic to review him from a hepatological point of view.
And when did that start?
I think it was after I became... there were joint liver clinics, but I set a regular basis certainly when I became director.
So that would have been after April 1991?
It was probably before then, because the first liver consultant that I worked with was somebody called Dr. Jeffrey Dusheko, who ultimately was the world authority on hepatitis C. And he came in 1988 from South Africa. And what I remember is that we tried very, very hard at that stage to try and access treatment for these patients. And that was before I was director.
Yes. Just sticking with the question of notes and what you might or might not expect to be recorded in notes. If at a patient consultation a patient was given information about the risks of non-A, non-B hepatitis or the risks of AIDS, would you expect that to have been documented in the notes of the consultation?
What do you mean by risk?
So if there was any discussion, whether by Dr. Kernoff or a registrar or anybody else, in, say, 1983 with a patient, in which that patient was given information about what was known about the risks of AIDS at the time, would you, based on your knowledge of practices and looking at the notes in subsequent years, would you expect that to be recorded in the notes of the consultation?
I don't know about 83. I can't remember. I don't know.
You've said that Peter Kernoff was a careful and meticulous,
Yes.
I think. Looking at his practices, so far as you knew them, you may not have known, would you expect him to record it if that had been said by him? Well, if you can't answer,
I can't answer it.
And then, again, just while we're talking about notes, obviously, as the 90s went on, the issue of VCJD arose. I'm not going to ask you in detail about that because that's fairly well documented in what you've provided to the inquiry and in some of your publications. But in terms of any conversations you had with patients specifically about VCJD, would you have recorded that in their notes?
Yes.
Going back to the question of the testing for hepatitis C, 1990 onwards, we looked at that letter, the model letter, June 1990. Over what period of time, as far as you can recall, did the process of testing the Royal Freeze patients for hepatitis C take place?
I don't know precisely, but I would have thought within a few months.
Of the test becoming available?
Yes. We actually had, I mean, on records, sadly some people had died. We had 310 patients who'd been infected with hepatitis C, and I think 30 of them had actually cleared it. So you're talking about a vast number of patients that we had to tell, although some of those patients would have died by 1990.
And so did you test the samples of every one of the patients who you knew had received blood products?
Ultimately, yes.
When you say ultimately, was that a period that took some time?
The natural history paper published in 2000 was clearly dependent on that. And because we had such meticulous records, we could actually look at the dates of when patients had a first infusion. And we knew from the previous study that if you had a first infusion, there's a 100% chance of getting infected. So in that paper, the 310 were identified because we looked back at the records to see when they had a first infusion. And we tested those sera. Some of them had already been tested. So that was how they were identified.
And so for the purpose of that study, perhaps we should just briefly look at it. It's WITN 0644088.
I think the other thing that perhaps I ought to just interject is the convention of writing papers. This paper, which is the first author, Dr. Yee, because she analysed the information, and she actually, I think, put this in towards an MD on the side effects of therapy. She has the first author here. My name at the end here is because I was overall in charge of the study. And Anya Griffin is an epidemiologist who looked after the data. And by this stage, although the Data Protection Act actually hadn't kicked in, we had already moved to a position that all data on computers was totally anonymized with codes. And Caroline Sabin, who's now Professor Caroline Sabin, was also an epidemiologist. And by this stage, she had moved to the AIDS unit, looking at their epidemiological issues. And I've already talked about Dr. Dusheko, who by then was beginning to be the most eminent hepatologist looking after non-A, non-B.
And so every patient should, presumably before this time, have been told their hepatitis C results.
Yes.
There is a reference, if you just go to page 2, under the heading Results, in the bottom half of the page, right-hand column, you refer there in the last sentence of that paragraph under the heading Results to there being 27 individuals who were consistently HCV PCR negative. They were thought to have cleared the virus and were studied in more detail. Are you able to say what the more detailed study entailed?
Yes, the specimens were retested, I think, to check. What you're dealing with here is you've got a positive antibody test and they're PCR negative, so they haven't got the virus anymore, and so they had cleared it. And interestingly, I think this is important, those patients who were co-infected with HIV, there were 3 out of that 100 who had cleared hepatitis C, which is quite extraordinary.
So the reference to further study there is a reference to repeat testing, is it?
I think so, yes.
When you first saw a patient after they tested positive for hepatitis C, whether it was because they'd asked to come and see you on receipt of a letter or at a consultation that was taking place in any event, what information do you recall providing to patients at that stage in the early part of the 1990s about their diagnosis?
Well, it would be the equivalent message that was in that letter, really. We would explain that the virus had been identified in 1989 and it was now possible to actually test and confirm that they had this infection. And I think certainly if I saw such a patient, I probably would have referred to the fact of when they first got it, that they got it when they would have had their first infusion. And of course, when we reviewed them, we had the hospital notes, we had all the notes in the centre, and we had the separate folder with the treatment records in, so you could find that out very easily.
And what was the system in place at the Royal Free for the ongoing monitoring of patients with hepatitis C?
Well, the patients, all patients with severe disease were ideally reviewed every 6 months. But of course that depends on patients coming. Sometimes patients didn't take up their appointments, but mainly they did. And certainly at their review, they would have had liver function tests done. And when we had the facility for doing testing, we would, when we could do the antigen testing, we began to look to see who had the antigen, and probably those people, once we began to have treatments, would certainly be reviewed at the Joint Liver Clinic. And more importantly, we became available to actually do the genotype of the hepatitis C. And again, this was information that would be passed with them when they were seen in the Joint Liver Clinic. And the significance of that was that once we had treatment, if you had what's called genotype 1, it was more difficult to treat. If you had genotype 3, it was more easy to treat with interferon and later with combination therapy. So that information was very important for the hepatologist, and that would have been shared with the patient. One of the other things I would say, and I can't precisely say the date that I started doing this, but it became my habit to copy the letter that was sent to the GP to the patient. The letter from the liver clinic, there was a dedicated secretary who did the special clinics. She would, the doctor, the hepatologist who was doing the clinic would review the patient, talk to the patient, and he dictated the summary then, and that summary was sent to the GP, and I would countersign it to make sure that there hadn't been any mistakes. But I don't know at what stage I started copying to the patient, and I also did that for reviews.
In terms of the joint liver clinic, was that something that would be offered to all patients in the early 1990s who had been diagnosed with hepatitis C, or only a subset of those patients?
No, it would be as soon as we had treatments available, all patients would be referred, because hepatitis C essentially could be cured. But this was very slow. I mean, it wasn't really... We had interferon first of all, which didn't have such a good success rate for genotype 1. It was quite good for genotype 3. And later, when we had better treatments, the people who hadn't succeeded in clearing would be referred. I think that's the answer.
In terms of treatment with interferon, you've referred in your statement to a study of 20 patients, and you said, well, sorry, I don't want to misquote you, so let's just see exactly what you say. It's paragraph 97. No, it's not that paragraph, but there is a question about that paragraph. If we could have up on screen WITN 06444058, please. And if we could go, first of all, to page 56. So this is paragraph 95 of your statement, and you refer, third paragraph, to two studies, the second of which is a controlled trial of interferon in 20 haemophiliac patients, and you say this, where we describe side effects as fever, malaise, lethargy, poor concentration and irritability were reported as troublesome in 80% of patients. And then you said this, but we found these tended to lessen as treatment continued and were generally tolerable when paracetamol was taken with the interferon injections. And then you go on to say side effects were very common, as is usual with interferon, although only temporary in the majority of cases, may deter patients from adhering to the demanding treatment regime. Was your assessment that the side effects of interferon were generally tolerable when paracetamol was taken based on the trial of those 20 patients or your broader patient experience?
I think at the time this was written, it was in the context of that trial. I think it's important at this point to say how we were able to access this treatment. When Dr. Dusheko came to the Royal Free, it began to be more common to treat patients as soon as we had a test to treat patients with interferon. But it was extremely difficult to get interferon for people with haemophilia. There was a reluctance to treat such patients. Before this trial, we had an experience with interferon because we had a patient who had HIV infection. And as I said earlier, everybody with HIV infection had hepatitis C. And one of the fairly rare complications of HIV infection is thrombocytopenia, a very low platelet count. And you can imagine a low platelet count in somebody with a bleeding disorder is pretty hazardous. And there had been a case report, I think, in the American literature, that intravenous interferon would be successful in treating such a side effect. And this patient, who's actually reported in the British Medical Bulletin Review, and there's a picture of it, was started on intravenous interferon essentially for the low platelet count. And what is quite extraordinary, he went on with this. It was given intravenously, which also was unusual because that was done because he had haemophilia. People who didn't have haemophilia were given interferon by, I think, subcutaneous injection. And his platelet count became normal. And ultimately, he was a carrier of hepatitis B E antigen. He converted, and because if there's another agent called delta agent that you get only if you have hepatitis B E antigen. So he had HIV, he had HCV, he had HB, and delta agent, and all those were cleared completely with the intravenous interferon. And he went on having that for some time. And I think, it's anecdotal, but there's no doubt that, well, maybe it's anecdotal, so there is doubt, isn't there? His CD4 count didn't decline at the rate of other people with HIV infection. So that was one experience we had. The lady who I keep describing, who had cryoprecipitate and got acute fulminant hepatitis C and was on ITU and things, a carrier of haemophilia, I looked after her, and I think it was Dr. Thomas who suggested that perhaps she would benefit from interferon. And she was on a really tiny, tiny dose for many years. And her transaminases went to a very low level. Ultimately, when, learning in hepatology, they realized what was the right treatment. She had a proper course of interferon. She had type 1, genotype 1, and she cleared it completely. And her son, who had severe haemophilia, who'd actually been somebody who had NHS concentrates, so he didn't have HIV, and he cleared it. So that was a previous experience kind of going into when we tried to get this trial going.
You'll appreciate that the experience of many patients who subsequently were on interferon was that the side effects were very far from tolerable and were intolerable.
Well, very what?
Were very far from tolerable.
It depended who the patient was. Some people did tolerate it. Some people had very bad side effects. It was. I mean, I think what is written here was the experience of these patients. Some of whom were Dr. Colvin's patients. It wasn't. You can see the results of this study. It wasn't at all successful. But we needed to move into a situation of trying to provide some treatment.
Can you recall what information or advice you gave your patients in the 1990s about the potential side effects of interferon?
Well, this study had ethical approval, and I'm sure there was a patient information sheet for it, talking about the side effects. And the patients, when we moved on, the treatment of hepatitis C was really clarified within the hepatology world, and we could genotype the patients, and it was really under kind of the direction of the hepatologist. The person administering the interferon, patients would come up, was a nurse specialist, and she would discuss the side effects.
Can we just go to the next page of the statement, please, Henry? The first main paragraph, you talk there about your natural history of HCV paper and what you describe as the lethal combination of HCV and HIV co-infection. And then you said this, hepatitis C is a very slowly progressive disorder with a 3% progression rate to a liver-related death from the time of HIV infection in 1985. I think you probably didn't mean HIV infection in the last.
Sorry, what?
If you look at the extract from the
I've got
statement.
the paper here. It comes from.
No, it's not the paper. I'm sorry. I wanted to ask you to look at your statement.
It comes from the Ye paper. This is from the Ye paper.
Okay. Could I ask you just to look at the statement for a moment, though? It
Yes.
should come up on the screen in front of you. That last paragraph, that sentence there says, for those HCV-positive individuals without HIV infection, we have shown that hepatitis C is a very slowly progressive disorder with a 3% progression rate to a liver-related death. And then it says from the time of HIV
Yes.
infection. I think that must be HCV infection.
No, the significance of this is that we were demonstrating that HIV is a lethal combination. We had already in 1994 identified that the people who'd progressed to cirrhosis were majority were co-infected. There were one or two people who drank a lot of alcohol, but mostly it was co-infection. This paper here is analysing the progression rate after they've got HIV infection to compare the people who were co-infected with the people who were not co-infected.
And so for those who had hepatitis C but not HIV,
yes,
that's the cohort in respect of whom you're saying there's a 3% progression rate to a liver-related death.
yes.
And can I...
This is 2000, so you're talking about the time they would have got the HIV was sort of 79 to 85, sorry. So that's why the analysis was done from 85, if you're comparing these two groups of patients.
And can I just ask you to explain, and again, this is a question I've particularly been asked to ask you, what's meant by the 3% progression rate to a liver-related death? How should that be understood on a year-by-year basis?
You mean why? How do you explain what 3% means?
It's a question of, if I may just intervene for a moment.
Sorry?
If I may just intervene, a rate
Well,
depends on
I
what
think
you're measuring
probably could we
it
look?
against.
I think in order to explain this, the question you're asking me, could we look at the Ye paper, which is, well, my number is 655088, or the other number I've got is 655084. I'm not sure which one it is you've got.
I'm not currently sure either.
It's
It's
the
83.
2000 paper from.
Is it? So it's WITN 0644088. Yes, thank you.
And if you turn to the fourth page. I mean, this becomes rather like the familiar graphs we keep seeing on our television screens from COVID. It's epidemiologic, the way epidemiologists present data. And if you look at the lower graph, if you look at the lower graph, that's progression rates to liver-related deaths from 1985 in HIV-positive and negative patients. And you see this very slow progression. And then the top one is any death, you see?
Yes.
At the top. And of course the difference between those is that, very sadly, those individuals who are HIV positive have died from, a lot of them have died from the HIV, although they might have been co-infected with, or they were co-infected with HCV. Is that clear, or have I completely bamboozled
I
everyone?
think we probably have enough evidence from elsewhere, including from the inquiry's own experts, about the progression, that
Yeah,
I don't need to
okay.
ask you more about that. Can I move to a slightly different topic and just ask you briefly about the use of porcine products? We looked earlier at an application that Dr. Kernoff had made in December 1983 for a clinical study in relation to porcine products. I'm not going to go back to that or go to, I think, your own publications on it, but you did, I think, for example, publish a case report about successful long-term treatment with porcine factor VIII.
And yes.
At the Royal Free, was porcine used solely for those with inhibitors?
Yes. Yes.
Would it have been suitable at all for use for those without inhibitors? And do you know whether consideration was ever given to that?
I don't think so. I go back to what I said yesterday. The reason for making porcine in the beginning was in Oxford. They realised there wasn't enough human blood to make human factor VIII at that time, and Macfarlane suggested making bovine factor VIII. They made bovine factor VIII. They took, I think, 3 patients' teeth out, and they got antibody afterwards. So he said, oh, we can't make bovine factor VIII, so I think they made sheep factor VIII, and they made porcine factor VIII. And subsequently, it became an extremely useful drug for treating inhibitors, not only in inherited haemophilia, but there is a condition called acquired haemophilia that predominantly occurs in elderly people, and it's an autoimmune condition. And it proved very valuable for that group of patients. And then subsequently, as time went on, Professor Euler-Hedner did a lot of research work, and ultimately there was a product called recombinant 7A, which was a most wonderful drug, extremely expensive, that we used to treat inhibitors. And it was first used in the war situation, or it was used in the war situation in Iraq, because you could use it to treat hemorrhage from wounds, and it slowed down the time to, if you had people killed injured in the battlefield, you could give them a shot of recombinant 7A and then get them to the field station. It was a very, very useful drug. So the answer to your question, we used then at the Free porcine factor VIII for inhibitors, and then latterly we moved to a recombinant product.
And could, in principle, porcine have been used for the treatment of haemophilia more broadly in those who did not have inhibitors?
I suppose it could have been, but you might have got inhibitors from it. I think probably tomorrow you're questioning Professor Tuddenham, and Dr. Kernoff and Professor Tuddenham published a paper in Blood describing the first use of porcine factor VIII, and I think he can answer these questions better than I can.
Can I just ask you briefly about factor XI deficiency? Not what it is. The inquiry has heard evidence in relation to that, but the Royal Free, as I understand it, treated more patients with factor XI deficiency probably than any other centre in the United Kingdom.
Yes, and this reflected our situation in North London, where there's a large Jewish population, and it has a very high frequency in Jewish people.
And in the 70s and 1980s, how, if we take it up to about 1985, 1986, what were the treatments that were used for those with factor XI deficiency?
Initially, fresh frozen plasma was used, And then a plasma-derived factor 11 concentrate was used. It was produced by BPL, and it was heated, so there's not an issue about transmitting viruses. One of the issues, which I don't think you were planning to talk about, variant CJD, but it's relevant to CJD, when this became an issue, the thing about factor 11 deficiency, you don't tend to get spontaneous hemorrhages. It particularly affects women with their periods and postpartum hemorrhage. And we looked after women who were pregnant with factor 11 deficiency, and sometimes we used to do it. We had another joint clinic, which was a joint women's clinic for inherited bleeding disorders, which I started in 1995 with an obstetric gynecology colleague. And for the pregnant women with factor 11 deficiency, she would write a birth plan. And that birth plan would require factor 11 to be given, maybe. And the ladies quite rightly said they didn't want it because it was plasma-derived. They might get variant CJD. And we did a study, which is in my list of publications in the CV. We covered them with recombinant 7A to stop their risk of bleeding. I think it's important to know that, factor 11 doesn't go up in pregnancy, but factor 8 does, and von Willebrand factor does. So it was quite a serious problem for those ladies.
The practical arrangements that were made at the Centre for the Treatment of Patients with HIV, when you rejoined full-time in 1987, what was the position in terms of how patients with HIV at the centre were being cared for?
I had a weekly clinic on a Monday morning, and depending on their medical condition, I would either review them monthly, or sometimes it might be weekly if they were becoming ill. And just to kind of give an idea of what that clinic was like, it wasn't until we'd identified that people were getting opportunistic infections when their CD4 count reached 200, the normal is 100. We realized that was when they were getting the opportunist infections, so we were able to give Septrin to cover pneumocystis. We were able to give drugs to stop the candida in their mouth and drugs to stop CMV, and that was done and also for tuberculosis. So that prophylactic treatment was done when they reached the CD4 count of 200. So basically, I suppose the way I reviewed those patients, and I saw those patients, and I can tell you, it was such a sad period. Between 1987 and 92, on average, we were losing about 8 young men, and sometimes not so young, a year. And the only thing we could offer these people was prophylactic treatment to begin with. And so we would use the CD4 count as a monitoring. And you don't want me to digress, but the way we arrived at that information was from the 1989 cohort study, where we realized that the CD4 count goes down in a line, and at the line of 200, that's the point at which these opportunistic infections are coming in. And so I was seeing patients, and clearly if somebody was ill, supposing, for example, they'd, recently had a septicemia or something, you would put the closer follow-up.
You've described how in relation to hepatitis C care, there were arrangements for joint clinics
Yes.
with liver specialists. What, if any, arrangements were there for bringing in others to the care of those with HIV? Did it fall to you to start with?
Professor Margaret Johnson, who ultimately headed up the Ian Charleston Centre, the AIDS unit at the Royal Free, because there was an enormous AIDS unit eventually, but in the beginning she was appointed in 1989, and she was a senior registrar in chest medicine, because initially the problem that was hitting was pneumocystis carinii, and patients were given pentamidine inhalations, and she, as a senior registrar, was beginning to develop that. In terms of expert input, to begin with, there was a joint ward round on Ward 11, which was where non-haemophilia patients were admitted, and the patient care was discussed. As soon as she became a consultant, we set up her coming to do a joint clinic with me. But clearly, we had a communication, and if I needed advice or help, I got it for her. But there was a formal, she would sit in the clinic. There was another person who was very involved, and his name appears on some of the reports. And he's now Professor Seng Lim in Singapore, a professor of medicine there. And he was employed as a research student under me, paid for by the MRC to run the Concord trial of zidovudine. And he became quite involved and quite expert clinically with these patients. So
the inquiry is aware from other information that there were patients at the Royal Free who were filmed during consultations, certainly consultations with Mrs. Miller and Dr. Goldman. Was that something you were aware of?
Yes, I was aware of it. Dr. Goldman, who I would emphasize is 90, and Reva Miller, who's dead, were both trained family therapists in the Milan method, and they did video consultations with signed consent, and occasionally I would sit in, but not always. I think you're going to have a statement from her probably, and I imagine you will ask her those questions.
But the consultations that you undertook as consultant would not have been filmed?
No, I didn't initiate it. It wasn't my practice. But I had sat in on consultations.
You referred during your evidence yesterday several times to the balance of risk and the choice between what you described as life-saving treatment and the risk of infection with non-A, non-B hepatitis. It was during the course of your evidence yesterday afternoon when I was asking you about risks of non-A, non-B hepatitis. What would you define as life-saving treatment?
Well, I think perhaps I would like to give you an example. Can I do that?
Yes, of course.
The very first treatment with factor IX concentrate, which was developed in Oxford, was in 1961. And a little boy of 4, who I think came from Edinburgh, had had a venipuncture, blood or taken from his arm. And he developed a hematoma, big clot. And that got infected. He then got osteomyelitis and gangrene of his fingers. This is 1961. And he was going to die unless he had an amputation. And the only way he could have an amputation was to have factor IX concentrate. And fortunately for him, Dr. Ritzer, who got phoned up because he'd been a senior registrar or something in Edinburgh, I think, where this child was, the child was flown down and he was given this factor IX concentrate and had an amputation. The reason I know this so well is because when I was editor of the journal Hemophilia, I ran a series of historical accounts to show how the treatment of haemophilia had developed and improved. And I asked Dr. Ritzer if he would write a commentary. The description of the amputation had been extremely successful. He survived and was published in a journal. And Dr. Ritzer wrote a commentary about this case. And, you know, Dr. Ritzer was another one who was very thorough, very detailed. He phoned up the patient. And the patient, I think by then, you can check in the publication, was about 36 years old. And he was very well. He must have had hepatitis C, unless he cleared it. And he played one-armed golf very successfully. That's really such an illustration of risk of the treatment versus the ability to save a life, really.
Would you accept that there will be many bleeds experienced by an individual with haemophilia where that bleed couldn't be described sensibly as endangering their life?
Yes.
And the balance could potentially be struck differently in such cases.
Well, it depends what you call a risk. I mean, if you, and I know that you criticised me yesterday for quoting Carol Birch and said, oh, this is 37 years ago, what kind of relevance has that got? I've got a facsimile of that original book, a report, which I had copied from the British Library. And I tell you, to look at that book is horrendous. The poor disabled people, it's awful. And, you know, you don't have a life threatening thing if you're disabled and have to limp and you have painful joints. But I think if you talk to patients, they would have appreciated perhaps having regular treatment and having treatment as soon as a bleed occurs. If you don't treat a bleed, it damages the joint, and ultimately the joint becomes bent. And, you know, we still had one or two patients at the Royal Free whose life was in a wheelchair. And with the gradual advent of concentrate, not only could you let the little boys have prophylaxis so that they didn't get deformity as they grew older, but you were able to offer some patients joint replacements so that instead of being in a wheelchair, they might be able to actually walk, and certainly their pain would be reduced. So when you're talking about risk, it may not just be, you know, stopping a cerebral bleed. It may be giving somebody a better quality of life.
I just wanted to ask you a little more about how decisions about risk would be taken or might be taken. Your evidence to the Lindsay Tribunal, and we'll just call it up, find the reference. It's LIND. Oh, you're ahead of me, Henry, thank you. If we go to page 28 and 29. So if we look just almost halfway down the page, well, in fact, we'll pick it up. Thank you, Henry. There's a question there. You indicated this morning that the parents of children with haemophilia opted for NHS concentrate as a preferable treatment option. Was that a matter that would have been discussed with their medical advisors as to the appropriateness of NHS product versus commercial product at that time? No. And then your answer went on to say it wasn't at that time the practice. to discuss the treatments that were being used with patients. Times have changed. And I just wanted to ask you a little about the approach to patient involvement in decision making. As I understand that evidence, but please correct me if this is wrong, the decision as to which form of treatment would be used was regarded at the time you're describing there as a matter for the doctor rather than the patient.
Yes.
You're there talking about the choice between NHS or commercial product, but the same, would that apply whether it was a choice between concentrate or cryoprecipitate, or concentrate or DDAVP? It would be the doctor's decision, not the patient's.
No, I think what is more relevant is the type of concentrate. So what we're talking about is plasma-derived versus the high-purity concentrates. I mean, that's was the decision that had to be made. And it was, when I'm talking about type, it depends, of course, what period you're talking about. I'm now talking about type when I'm there, and the type was defined by the doctor according to the recommendation of UKHCDO. Actually, you would go by guidelines. The type, that's not talking about the manufacturer, and of course by then they're all heated anyway.
I don't know whether you can answer this because it's a time before your director that I'm really asking you about, but to the best of your understanding, what would your expectation have been of the patient's involvement in the late 70s, first half of the 80s, in decisions about their treatment?
I can't answer that. That was not my decision making.
Would you agree with this, and this is a general question rather than specific to any particular point in time or any particular centre, that the question of that balance of risk question that you identified may depend upon the level of risk that the individual patient is willing to accept?
When we look at risk, it's partly how much the patient's going to accept, but it's also what is likely to happen after this first presentation, what the risk is going to be. And often you don't know.
The clinician's role may be to advise, to inform the patient, but ultimately the judgment as to whether the patient wants to run the risk of being exposed to a virus or run the risk of sustaining damage to their joints or limitations upon their lifestyle, would you agree that that ultimately is a decision for the patient?
I can't answer that question.
If we move then to, just in relation to stored samples, the practice of storing samples at the Royal Free began, you've told us, in 1978, obviously well before you arrived there. But your statement explains why you say those samples were stored. And if we look at the bottom of page 5 of your statement, sorry, Henry, it's WITN 0644058. Page 5. You say towards the bottom of that page, I think it is important to add that that samples used were stored for clinical management and treatment of patients with haemophilia. We know they were used subsequently for testing, analysed for the purposes of the research studies you describe. What did you mean by clinical management and treatment? In what sense were the stored samples used for those purposes?
Exactly what you've just said. You said, say what you just said again.
The samples were ultimately, a number of years
Yes.
later, used for testing. Was that the purpose, in part, of storing them in case a virus was identified in
I
the
think
future?
it depends how you define clinical management.
But they were your words, Professor Lee, which is...
Yes, I know. Well, how
So-
I would... clinical management was everything to do with managing that patient, and knowing what was happening was part of that management. The only way that we could find out about the fact that 100% of people got hepatitis following exposure to concentrate, and that commercial concentrate was just as much risk as NHS concentrate, the only way we could find that out is by using stored samples. I would think that knowing that information was part of clinical management.
And do you know, as a matter of fact, what information was provided to patients about the purpose for which the samples were being stored, or indeed the fact that the samples were being stored?
They were told that the samples were being stored. The blood in the centre, we had a dedicated 4-bedded area, and the people who took the blood were the nurse specialists, and they would say that that was included in the spectrum of samples that were taken. But you can't say what it's going to be used for when, for example, it was ultimately used to tell the genotype or the fact that somebody had got an antibody to hepatitis C, when in this stage you don't even know that there's going to be hepatitis C identified. I would also say that the clinical management of our patients with HIV was tremendously helped by the fact that there were stored samples, so uniquely we could find out when people had been infected, and later on, with the help of the regular assessments we made of immunology, that wasn't for research, that was to know whether somebody needed drugs or were getting ill. The studies on that information was so valuable to clinical management, not just for people with haemophilia, but dare I say it, and it may sound terribly conceited, but worldwide, because I think nowhere in the world did we have such a regular assessment of patients. And we were able to demonstrate that the opportunistic infections came at a CD4 of 100, 200, and later, in one of the papers that I've submitted to you, in 1994, we were able to show that some 25% of people 20 years after they got infection would not have AIDS. And that was an important, clinical management is not just doing drugs and things. It's important to tell people their prognosis. And again, that was information that was important for the patients that we were caring for. It was also terribly important in the world, And the other thing about knowing that when the CD4 count reached to 50, patients were very vulnerable. So, we might bring them up more regularly to follow them up. So I think, clinical management is the whole patient and what is happening physiologically and pathologically to them.
Were those samples ever made available to anybody or any organisation outside the Royal Free Haemophilia Centre?
The only thing I can think of was after I retired, they were offered outside, and I'm sure you've got all the references to that.
Yes,
I was very cross about it.
And that's an issue I'm going to explore with Professor Tuddenham tomorrow.
Sorry?
That's an issue I may need to explore with Professor Tuddenham tomorrow.
I think in all fairness, since I'm here,
Yes.
could I comment on it?
Yes, certainly. Yes, I think you want...
Could we have it up?
Are you talking about the article in the newspaper?
The newspaper article.
Let me see if I can find the reference, Professor Lee.
I've probably got the number. Do you want it?
We've got it somewhere. WITN 064410. No, that's the wrong one. Forgive me. HSOC 0021123. I think. I'll find out. Is this the newspaper article you're referring to, Professor Lee? Patient's fury over blood test betrayal.
And the date of this is the 3rd of June, 2007. Are you going to talk about variant CJD today or not?
It rather depends on how much time we have, because there are some other issues I need to cover
I'll just
first.
very briefly make a comment. This is 2007. I retired in 2005. The Data Protection Act was 1998, made into law in 2000. So the first thing to say is that I knew that you needed ethical approval for any kind of thing like this. That was the first thing to say. The second thing to say is that because of my involvement with the Transfusion Transmitted Working Party, and as you know, for 2 years, I had constant contact with the Department of Health in order to get a multi-centre ethical approval for follow-up of patients. I actually became quite knowledgeable about variant CJD. The National Institute for Biological Standards and Control was almost as it says. In the world of hemostasis, you need control bottles of factor 8 so that, you know, a lab in London is measuring the same thing as a lab in Edinburgh. So they're control samples. A scientist from the, as I understand it, a scientist from the National Institute of Biological Control was at a meeting in America about variant CJD. And somebody, I don't know who, at that meeting must have heard him say, oh, it's possible to access specimens at the Royal Free. And he'd had a conversation with Professor Tottenham, presumably. I was very cross about this because, you know, although you might say, you know, I was testing people without consent in 1983, things have changed. And actually, we're being told not to do that now. But even more importantly, it's more important than the consent, was there wasn't a reliable test. We didn't know whether people were at risk or not at risk. So here's these specimens being offered to this scientist at National Institute of Biological Control to do tests that then you're going to tell a patient that they've had this test. You don't know whether it's really sensitive. You don't know what it means. I get phoned up. I feel very cross about it. I was actually on holiday in Ireland. I got phoned up by a journalist saying, you've been testing patients. And it was wrong. And that's why.
And you're reported in this newspaper article as saying you can't go around just grabbing stored samples. And then it says, acknowledging that she had used samples for hepatitis and HIV infection research at an earlier time, she said that attitudes had changed. You can't go ahead and test people without their knowledge. It's just not on. Is that an accurate summary?
Yes, it is. What you said? And you know that's what I said. But I think it's more than that. When those patients, well, it's not more than that actually, because the initial tests for HIV, we didn't necessarily know that they were sensitive or whatever. So we're talking about from 1984 to 2000, and, you know, 2007 actually. So what's that?
23 years. 23 years.
Yes.
So I note the time. I still have some further questions for Professor Lee, and also obviously recognise legal representatives need to have the opportunity to suggest to any further questions that they would wish to have asked. So is it sensible to take a break now? It might mean obviously sitting a bit late tonight in order to complete Professor Lee's evidence.
Well, let me ask Professor Lee. I saw you looking at your watch a moment or two ago, so I suspect you could probably do with a break. But
I think so.
Very well. Let's do that.
And sir, can I suggest, so that I have time to consider any questions proposed, that we take 40 minutes, 45 minutes?
Yes. Well, let's say we'll come back at 4 o'clock, shall we? That gives plenty of time. I
Thank you.
would hope.